Good morning, everyone. Hope you are all fine. So we were discussing about fungal infection in the few classes, and I think it was very clear about superficial mycosis that is affecting human beings. Then comes subcutaneous mycosis that is affecting the submucosous layer and the superficial layer also. And then we discuss about systemic mycosis, followed by opportunistic fungal infections, where the initial opportunistic fungal infection was candidiasis. And about opportunistic fungal infection, they are the fungal infection we know it is mainly affecting the persons who are having low immunity. Not only low immunity people, the persons with having autoimmune disorders, then tuberculosis patient, some pregnant ladies can also be affected. All these conditions only opportunistic infections occur. So the second opportunistic infection today what we are learning is aspergillosis. Before going into the session, what are the benefits of this lecture? What's the outcome of this lecture? As the outcome of the lecture, you will be able to understand how many species of aspergillus is there, what are different kind of aspergillosis infections affecting human beings, what is the antifungal agents used to treat this respiratory tract infection, and what is the clinical symptoms of disease. So overall, after the session, you will be able to understand the pathogenesis, the mode of infection, and the treatment of the disease. So shall we move on? Telling about aspergillosis. Aspergillosis refers to invasive allergic conditions that may be caused by the fungus Aspergillus. And this Aspergillus is a common species of fungus seen in our environment. The different species of Aspergillus include Aspergillus niger, flavus, fumigatus, terris, and nidulensis. So as you can see in the picture, the fungus usually has a hyphae. From there arises the conidiophore. From the conidiophore we has a vesicle. After vesicles comes medulla, and from the medulla phylates comes out, and finally from the phylates we are having the spores or the conidia. By inhaling the spores or conidia is only we are getting infections. And when we tell about aspergillosis, it is mainly causing respiratory tract infections. And this species of fungus is commonly seen in the decaying matter and soil. Usually, the pathogenesis or what is a real infection? It is a respiratory tract infection. In human beings, it causes respiratory disease, invasive aspergillosis, and superficial infection. The most common form of aspergillosis include the clinical conditions are allergic bronchopulmonary aspergillosis, bronchial asthma, allergic alveolitis, aspergilloma or fungal boil, acute angioinvasive pulmonary aspergillosis, and chronic cavity pulmonary aspergillosis. So these are the common type of pulmonary aspergillosis that you see in humans. So in humans, the common is pulmonary aspergillosis. In pulmonary aspergillosis, you have bronchial asthma, allergic alveolitis, cavity pulmonary aspergillosis. This picture is showing you the infection inside the lungs that is known as aspergilloma. In the case of aspergilloma, the fungus will be colonizing in the pre-existing pulmonary cavity. So what happens? The alveoli is really affected. And inside the alveoli, the fungus multiplies and it forms a web-like structure, as you see in tuberculosis or any cystic disease. So what happens really? The alveoli will be blocked. So inhaling of oxygen becomes very difficult. And there comes the respiratory problem. So aspergilloma is otherwise known as fungal boil. And this is the postmortem picture of a lung who was postmortem picture of a child who was infected with aspergillus fungus. It shows the cavitation inside the lungs. And then the second type of aspergillosis includes invasive or disseminated type. Here dissemination means spreading. So not only in the lungs, the infection may spread to other areas such as brain, kidney and heart. That is the second type of aspergillosis, that is invasive aspergillosis. Apart from pulmonary and invasive aspergillosis, the third type includes the aspergillus infections affecting other areas. That means cardiac aspergillosis, cerebral aspergillosis. Cardiac means affecting heart, cerebral means affecting brain. Ocular aspergillosis, that is affecting the eyes, which may be characterized by keratitis and endophthalmitis. It may also affect the ears, which may be characterized by otitis externa, that is ear infection outside. It also have other infections such as nail bed infection, which is known as onychomycosis. So there are other forms, these are the other forms of aspergillosis in spite of pulmonary and invasive. So in spite of pulmonary and invasive, the other type of aspergillosis include cardiac, cerebral, ocular, ear infection, nail bed infection, mycotoxicosis. And it also includes invasive sinusitis, which may be seen in allergic persons. Here, allergic fungal sinusitis may occur. Then, what are the clinical symptoms? Before going into the clinical symptoms, I already mentioned to you that the common species of aspergillus include fumigatus, flavus, and niger. When we tell about fumigatus, this aspergillus fumigatus is mainly causing acute pulmonary and allergic aspergillosis, whereas aspergillus flavus will be usually causing infections on the skin and also ocular infections. In the case of aspergillus niger, this aspergillus niger is mainly colonizing in our respiratory tract. So what are the three species? Aspergillus fumigatus, that is causing acute pulmonary and allergic aspergillosis. Aspergillus flavus, which is seen in hospital infection, and Aspergillus niger, that is commonly causing invasive infection in human beings characterized by respiratory tract and otitis externa. Coming to the laboratory diagnosis, for each infection we need to know what is a lab diagnosis. When we tell about lab diagnosis, in the case of aspergillosis, as it affects the lungs, the specimen collected is sputum or tissue biopsies. And once you collect the sputum or tissue biopsies, the specimen is observed under direct microscopy, which is seen under the potassium hydroxide or 10% potassium hydroxide microscopy, and it is either observed by histopathological staining. So that is the lab diagnosis. So in the case of lab diagnosis, what is a specimen? Specimens are either tissue biopsies or sputum, which can be observed by 10% KOH. And when you observe these specimens under the microscope, you can see narrow septate hyaline hyphae. That is a picture you see here in the slide. And coming to after microscopy, we will be following the culture. And the culture, the specimens are inoculated into the common culture medium, that is Sabbros dextrose agar. What is a fungal culture medium? The fungal culture medium, that is Sabbros dextrose agar. To the Sabbros dextrose agar, we are inoculating the specimen, which is incubated at 25 degrees Celsius and also at 37 degrees Celsius. After 5 days, we will be observing for the colony morphology. So both the colony morphology is observed. That is, we look for the macroscopy. What is the color of the colony? What is the texture? Whether is it pigmented? Whether it is fluffy? Whether it is cottony? So that is all the macroscopy. Macroscopy means looking by the naked eyes. And in the microscopy morphology of the fungus is observed by the fungal staining, that is LPCB mount. LPCB mount means lactophenol cotton blue mount. And when you see this fungus by the lactophenol cotton blue mount, we can observe the real morphology from where you can see the vesicle and the fungal-like projections of the conidia projecting outside. The slide shows you the different species of Aspergillus in LPCB and also its cultural characters on SDA. I think you can very clearly see how the fungus is very beautifully demonstrated, very beautifully stained when you are doing with LPCB or lactophenol cotton blue is the real staining method where you can observe the colony morphology of the fungus. And after microscopy and culture, we will be going for serological diagnosis. So in the case of serological diagnosis, we can do antigen detection, antibody detection, and also skin test. In the case of antigen detection, we are using beta-D-glucan antigen assay or galactomannan antigen. And these are the two common antigen assay which is used for detecting the fungal infection. Whereas in the case of antibody detection, the serum of the patient is taken and it is observed for the antibodies that is used to detect chronic invasive aspergillosis or aspergilloma. So if you have your antigens may not be correctly detecting in certain cases. So in certain cases such as chronic invasive aspergillosis and aspergilloma, when the culture becomes negative, we will be taking the patient's blood sample, and from the blood sample we are observing the antibodies. So in serology, after serology of antigen detection and antibody detection, what we can do the skin test. Okay, skin test, allergic skin test are there where we are detecting the fungal infection. And the last part of the lecture tells us what is the treatment or how will you treat the disease. The treatment includes common antifungal agents, but the antifungal agents may be different for each type of species. The common antifungal agents are, one is invasive. For invasive aspergillosis, we are using voriconazole. So for invasive aspergillosis, what we are giving? Voriconazole. And for allergic bronchopulmonary aspergillosis, you are giving itraconazole. And if it is aspergilloma, that is fungal ball colonization inside alveoli, sometimes surgery may be recommended. For chronic pulmonary aspergillosis, we are giving itraconazole or voriconazole. So mainly you can give antifungal agents, but when you are giving antifungal agents, the difference occurs because the species, the antifungal agent for a Niger may be different from fumigators. That is what we are observing in our LPCB mount. When you observe the LPCB mount or lactophenol cotton blue mount only, we can decide which antifungal agent is to be given. So for allergic bronchopulmonary aspergillosis, we are giving itraconazole, and for chronic pulmonary aspergillosis, we are giving itraconazole. Okay, so that is the conclusion of this lecture. So what all we learned? We learned about the different species of aspergillosis, what are different clinical conditions caused by the aspergillus species. Okay, how will you do the diagnosis by taking the different specimens, and how is the colony morphology observed, and finally how will you treat the infection. So this is the second opportunistic infection. So the first one was Candida and the second one was aspergillosis, and then we have mucormycosis, which will be taken in the upcoming class. I hope it is clear for everyone. Now you can ask me any doubts regarding this topic. That is the session now open for. Okay, clear? Thank you and have a nice day.